Hello, and welcome to Patient-Centered GA Care, a synergistic approach to optimize management. I'm Dr. Stephen Ferrucci, Chief of Optometry at the Sepulveda VA Ambulatory Care Center in North Hills, California, and Professor at the Southern California College of Optometry at Marshall B. Ketchum University. I'm joined today by my friend and colleague, Dr. Carolyn Majcher, Director of Residency Programs and Professor at the Oklahoma College of Optometry, Northeastern State University in Tahlequah, Oklahoma. Welcome, Carolyn.
Thanks for having me, Steve. It's a pleasure to be here.
You got it. Today, we're going to be discussing considerations for the monitoring of patients with geographic atrophy secondary to age-related macular degeneration. So, Carolyn, as we know, we now have two FDA-approved therapies for the management of geographic atrophy secondary to AMD, further reinforcing the need for early detection to prevent GA progression. In your patients with AMD, how often are you seeing these patients to monitor for signs of geographic atrophy?
Yeah, Steve, that's a great question. And I think it depends on the stage of macular degeneration. So patients with like early AMD, I'm usually monitoring at a 12-month basis versus intermediate stage, non-exudative AMD, it's like 3 to 9 months typically. And that really depends because that intermediate stage of AMD encompasses such a large spectrum of disease severity and progression risk. So I kind of think about intermediate stage AMD as like high risk and low risk. And individuals with being high risk intermediate stage, I probably am going to monitor every 3 months. And these would be patients that maybe have geographic atrophy or neovascularization already present in the fellow eye that puts them at very high risk of developing advanced stage disease, have maybe large multiple soft drusen bilaterally or a combination of soft drusen along with reticular pseudodrusen or significant pigmentary abnormalities. I mean, these are patients going to watch really closely versus those with what I would term like lower risk intermediate AMD, then I'm probably going to monitor them every like 9 months, give or take.
I think you bring out a good point that not all intermediate patients are exactly the same, and you really have to customize it, I think, based on that patient's individual situation, risk factors, clinical presentation, what have you. As we know, GA progression is variable, varies in patients. How do you take that into consideration when you decide, once you made the diagnosis of GA, how frequently you want to follow those patients, specifically with GA?
I mean, yeah, it's really a challenge, right? We know that the rate and the pattern of geographic atrophy progression and development really significantly differs among individuals. So, I'm going to watch patients that have non-center involving geographic atrophy and good useful vision, certainly more closely than maybe someone who already has very large area of geographic atrophy that's involving the foveal center. And the reason being, right, is that patients with non-central GA, good vision, they have more to lose. And we also know that non-central geographic atrophy progresses faster than patients that already have center-involved GA. And I think it's important, especially, if it's a patient I'm referring for potential treatment with complement inhibition intravitreal therapies, that I want to be like a cheerleader for them. So I'm going to recall them back to see me pretty quickly upon that referral, like probably to then come see me again in like 3 months so that I can be an outside perspective and tell them, hey, this treatment is really working. It's important that you stick with it and be a cheerleader for their compliance, and hopefully they can maximize what vision they get out of that treatment regimen.
Yeah, all good points. Yeah, the other thing too, I like to use what happened in one eye as a precursor of what might happen in this eye. So if I see, advancing geographic atrophy or really bad geographic atrophy in one eye, makes me think that the other eye could follow suit. So I also think that's a important consideration as well.
Completely agree.
Excellent. We know that GA, there's risk factors with macular degeneration as well as geographic atrophy, lifestyle changes, and what have you. How do you talk to your patients about those risk factors?
Yeah, I've actually developed my own handout on something like this that I give all my patients with macular degeneration. First and foremost, we know smoking is the most significant modifiable risk factor. And smoking has been demonstrated to increase not only the development of geographic atrophy, but also increase the risk of expansion and enlargement over time. So that's a really important conversation to have with patients who are currently smoking. I also recommend UV protection when outdoors and briefly discuss dietary modifications that would include increasing in their diet foods rich in antioxidants, vitamins, minerals, carotenoids, omega-3s. Conversely, limiting the intake of foods that are high in cholesterol and fats, especially like saturated fats and highly processed baked goods. And then controlling associated systemic comorbidities. Is AMD a systemic disease? I think Dr. Pizzimente would ask. So controlling hypertension, dyslipidemia, obesity, I think is also very important.
Yeah, I agree 100%. It's interesting. I read a study that said both optometrists and ophthalmologists are not great about counseling their patients about the dangers of smoking, but being the number one modifiable risk factor for AMD, as well as its progression, I think it's uber important. So I think we really owe that, quite frankly, to our patients. And I do think having a handout is excellent because, they can take it home, they can look at it, remind themselves after they leave the office.
Yeah, there's so much to discuss when you have a patient with macular degeneration. Sometimes I know they can only, take in so much and remember so much from that conversation. So having something that they can physically take home with them, I think, is important. And having family members in the room while we're having that discussion in case the patient forgets something, I think is also really important. And the other thing I want to mention too, Steve, is that I'm really fortunate to be practicing in a hospital setting, like an IHS type of facility, where we can refer for smoking cessation programs. So looping in like the primary care provider to even get like prescriptions on board to help these patients stop smoking is really important.
Yeah, I think that's a great idea. How do you talk to your patients with geographic atrophy about their potential for vision loss?
Yeah, it's challenging, right? But I think it's really important to emphasize two things regarding vision loss from geographic atrophy, that it's progressive and that it's irreversible. And I love having a visual to show a patient their own geographic atrophy. And if I have like a series of images, say fundus autofluorescence images, where I can show the patient, this is how your own geographic atrophy has been enlarging over time, and it's likely to invade the center of the fovea in X number of years or whatever, or months even. That's certainly something that I think is really powerful in patient education, that they can see that this is progressive, and once we lose the vision, we cannot bring it back.
Yeah, all good points. You mentioned fundus autofluorescence. What imaging modalities are you currently using to monitor for progression of GA, and what markers of disease or signs are you looking for?
Yeah, so I incorporate multimodal imaging technologies, so OCT, fundus autofluorescence, near infrared reflectance. I think OCT is probably the gold standard in diagnosing early geographic atrophy. Once it's already pretty well established and I'm trying to monitor for enlargement or progression over time, then I'm more so utilizing fundus autofluorescence and like near infrared reflectance. And for everyone out there, near infrared reflectance is just like the grayscale image that usually comes with your OCT scans to show you, say, like where a raster scan was taken. So I think a lot of practicing eye care providers probably have access to near infrared reflectance and just aren't aware of the fact that they do. And it's a great way to monitor for progression of geographic atrophy. I rely little or less on, say, color fundus photography, especially if it's like wide field color fundus photography. That's not a great way to detect or monitor progression of GA. Also, best corrected visual acuity is not a good way to monitor disease progression either, because you could have, let's say, a non-central geographic atrophy lesion that's enlarging over time, and the visual acuity is like 20/20, and it's still rocking 20/20, even despite enlargement of that GA lesion. The only time acuity is going to decrease is when you cross that threshold, right? From non-center to center involved geographic atrophy. And so don't utilize best corrected visual acuity as, your marker of progression or as a marker of when to refer a patient for consideration of complement inhibition. We want to save patients' vision when it's still good, because all we're doing is slowing down the progression. The quicker, the earlier we slow it down, the more vision we have to save.
Yeah, no, 100% agree. I mean, in a way, with geographic atrophy, once their Snellen acuity is reduced, it's almost too late, in a way. You really want to prevent that in the first place. There's in some of the early studies, there's been some, looking at low luminance, visual acuity or reading speed and other measures for, damage in these patients with geographic atrophy. And I think it's a great idea, but I just think clinically it's very hard to work it into your clinical flow. Do you find that to be true?
Yeah, I don't typically measure things like that, but I do like heavily rely on my friends in low vision rehabilitation. And I know that they check things like contrast sensitivity in that, but I don't use it as like a marker for progression of geographic atrophy, no.
Yeah, and I agree with you about color photos. They're great because everyone has access to a fundus camera, but late lesions are very easy to see. But you can miss some very subtle early lesions that are really detectable much better in OCT or NIR or on FOS. So, I think utilizing whatever technology you have, but the more technologies you have to look in different ways, the better off we are, obviously.
Yeah, and I think, OCT is so valuable in early assessment of geographic atrophy and also in just like intermediate stage AMD before patients have geographic atrophy in detecting those high risk OCT biomarkers for progression to GA, like impending geographic atrophy lesions where you have subsidence or sinking of the outer plexiform layer, a pair of hyporeflective wedges, loss of the ellipsoid zone, or even like reticular pseudodrusen or subretinal drusenoid deposits can be really subtle, right, on color fundus photography, but are so much easier to see on OCT. And that's like a specific drusen subtype that we know is high risk for geographic atrophy development.
Yeah, 100%. I think, we really have to pay a little more attention to the OCT in our patients with geographic atrophy to look for those subtle signs because they can be subtle and they can be overlooked if you're not paying attention. What do you think of the role of newer technologies, whether it's swept source OCT or some of the new machine learning algorithms and telehealth and teleretinal and these sort of things? How do you think those might change, how we look at or how we follow these patients with geographic atrophy?
Hey, technology in the retina landscape right now is such an exciting thing. I see it in so many ways. Our imaging technology, like OCT, with the addition of swept source, I mean, the resolution just keeps getting better and better and better, where we're going to be able to identify even more biomarkers for progression of geographic atrophy. And so, I think the future is really bright on that, Steve.
Yeah, I agree. Who knows what the future brings, but it's exciting for sure, I feel. Any final points you'd like to make about geographic atrophy and how we can help our patients with geographic atrophy?
Yeah, I think optometry, we really serve as these primary eye care providers, and it is our duty in patients, when we're seeing patients with macular degeneration, to detect the earliest treatable features possible, right? So whether that's geographic atrophy now or neovascular exudative AMD, and utilizing multimodal imaging technology is absolutely critical if you want to detect treatable disease in its earliest form, with OCT really being the shining star of those imaging modalities. So when we're taking, say, our macular cube scan, how important it is to scan through like the entire cube of data, looking for areas of GA and looking for, say, fluid or pigment epithelial detachment, et cetera, that may be suggestive of treatable disease.
Yeah, well said. Very well said. Well, thank you, Dr. Major, for the excellent discussion, and thank you for listening. Please remember to take the post-test and evaluation to receive CE credit and to tune in for additional episodes within the podcast series.